Same.
Okay. So I don't know much about, I don't know how to speak much in Spanish, but I have trained some words to introduce you. So, buenas tardes, Roberto y Rosa. Muchas gracias por aceptar nuestra invitación. Ahora hablaré en inglês porque solo aprendí este comienzo en español. So, Portuguese is not the same as Spanish, as some people think here in Brazil, but thank you so much for attending us and share with us all your knowledge. And you and Rosa are brilliant guys, brilliant ones. So as you see, Eduardo is attending our lecture, so he's interested. So in how you said it, he's like a god in retina to us. So
yeah.
and he's here.
He's the really big boss.
Yeah,
because I'm old.
Yeah. not so that. So please, Roberto and Rosa, you share with us.
Thank you very much, dear friends. It's a real privilege to share these minutes with you. We had no doubt when Ricardo kindly invited us to share some discussions, actually, because Rosa is not aware of what's going on today, which is kind of fun for me. Hopefully, you all learn a little bit, have a lot of fun during the next few minutes. And again, thank you very much for the kind invitation.
Thank you.
So here's the thing. These are color fundus photographs of patients with AMD. And this is the first question that I have. Rosa, how do you classify that?
Well, I will say the first patient on the first row on the left, it's hard Drusen, more related to aging, not mainly to AMD.
And how do you stage that within AMD? What's your staging with that image?
No, if I only see hard Drusen, I normally stage as aging, not AMD.
I understand, okay.
Yeah, then when you see a small Drusen, but I don't see any here, maybe the third one, but I think there are subretinal Drusen like deposits. So though the rest, the 5 other patients, I think they are more on the intermediate, because I see intermediate and large Drusen with pigmentary changes. And the problem is that, for example, the image on the first row, the one on the right side, there's no really classification for that, because I see a small Drusen, so I will say maybe early AMD, but we will see that that kind of deposits have a lot of risk, and we don't have that in the classification right now.
I can see that you are very interested in talking today. Thank you for coming. So in summary, is it enough to classify patients in our clinic with fundus examination itself?
Not at all. You are missing a lot of information.
So that was the response, actually. So the response was like, come on, Roberto, we cannot do that. That was done in 1995.
Well, but I'm trying to do a complete description.
That's wonderful, and we appreciate very much that. But please consider that this is a very important part of our routine examination for patients with AMD. But we should move on. We cannot play today game with the rules from 20 years ago. Similar situation, FA. Okay, Rosa, please. I promise these are all neovascular AMD cases. Can you classify that, please?
I don't normally use the angiography classification.
You don't use that?
Only? No, I normally use the tomographic classification, because I think it adds a lot of prognostic value on the types of neovascularization.
And actually, if we only use FA for the classification of neovascular AMD, we should be using the rules published back in 1991, a long time ago. Again, we should move on. So we use OCT, right?
Mm-hmm.
also for atrophy, or do you think all these patients fit within the category of atrophic AMD, and you have enough information for that?
Well, the thing is that normally we use the term geographic atrophy, and that's also an old term. And yeah, on the 70s. So it's there are many groups and consensus, international consensus, trying to classify or better approach the atrophic changes in AMD. So I think also we have to use OCT and other modalities.
And what about first patient, top left, with macular atrophy secondary to CMB? Is that geographic atrophy?
That's more macular atrophy based on the actual.
Yeah, I think you should clarify that for us later. So as Rosa was saying, the term geographic atrophy was introduced by this talented gentleman, Donald Gass, 1970, long ago. So what about OCT? Because I have learned that you talk about neovascular advanced form of AMD when you get CMB. Am I right?
Not always.
Not always. These two patients have neovascularization clearly visible in the OCT scans. So they have an advanced form of AMD.
But there's no exudation due to this neovascularization.
Never.
So, yeah.
And they have never been treated.
Yeah, that's a good point to establish, because when we use treat and extend regimens, sometimes we see this kind of image, but we are undergoing treatment. But if there's no history of treatment, we have to think on intermediate AMD and subclinical or quiescent neovascularization with no exudation. So this is fitting in the intermediate.
So the presence of neovascularization doesn't mean that you have advanced form of AMD. Is that right?
Not always.
Okay. So we have a lot of new information coming from the OCT, and we really don't want to fit that into very old categories, staging forms of AMD. All these patients cannot be fitted in any of the stages or forms of AMD as we knew them. So we really need to purify the strain. And that's what we're going to try. Because AMD actually is a non-stop journey throughout the entire life of our patients. That's a beginning and an end, start and finish. We start with pigmentary changes in Drusen, as you all know, and the end of the story is atrophy. In the middle of that journey, eventually, CMB, is CMB right?
No.
No, sorry. Macular neovascularization may develop in some patients, trying to stop that journey. This is very unlikely to happen in many cases. So this is the general overview of what happens with AMD in all cases. That only depends on how long the journey will be. And there is an increasing need to perfectly phenotype both intermediate and advanced forms of age-related macular degeneration on the basis of all the new imaging modalities, but mainly structural OCT. So let's begin with the very easy, for Rosa, not for me, things. This is a little checklist that we have prepared and put together, and we're going to see each one of these things. All of them are OCT-based descriptions of patients with intermediate AMD. 3 of them will be very important for a little issue that we will discuss later. So we were taking a look at these images before. What do we see there, Rosa?
So we see detachment of the retinal pigment epithelium. It has been described as double layer sign. When we see this detachment, normally it's quite shallow, not really.
Shallow is a beautiful song also.
Yeah. So how we know it's detached, because we see content below the hyperreflective line of the RPE, and also we see the Brooks membrane here. And I see irregularity of this detachment, but I don't see any exudation or exudative changes.
Is there a name for that?
Yeah, it's shallow irregular elevation.
Mm-hmm. So it is kind of a consensus in that, in calling this.
This was reported by this Australian group. And yeah, normally now there's a consensus on calling these elevations of the RP without exudation SIRE, or shallow irregular RP elevation.
But this is not only seen in patients with AMD, is that right?
Well, you can see that in maybe in pachychoroid disease. It's quite typical, this kind of type 1 neovascularization below the RP.
Okay, we will go into further detail later. So an OCTA in such cases might be helpful, right?
Sure, yeah. Although if you don't have, you can suspect by the aspect of the content of the RP, but it's really useful for these cases.
Got it. So the group led by Phil Rosenfeld in Bascom Palmer has developed the key clinical studies on this non-exudative macular neovascularization with a baseline prevalence among patients with intermediate AMD of about 15% of cases, which is quite a lot. It looks like quite a lot. There is a new development of these shallow irregular RP elevations in 5% of cases after 1 year of follow-up, almost 10% of cases after 2 years of follow-up. And there is which is very important. They are non-exudative, as Rosa has explained. So what is the percent of patients who develop an exudative shift and need injections at 12 and 24 months? If they don't have this kind of non-exudative macular neovascularization at baseline, you can see the percentage of patients developing exudation, very little, around 6%. But if they do have this non-exudative macular neovascularization, it's 20% of them developing exudation at 12 months, 34.5% of them developing exudation at 24 months of follow-up. So we should be careful. And following non-exudative macular neovascularization in patients with intermediate AMD gives an individual risk, just by this, of 15 times fold increase of exudation compared with those patients which do not develop this kind of situations. Somehow, this is a summary in a graphic illustration of all what we have been discussing. We need to recognize the shallow irregular RP elevations in patients with intermediate AMD. If we have OCTA, wonderful, we can really document that, but we need to carefully follow them because they develop exudation at a very high risk and a very high proportion.
How often do you follow these patients?
I often follow those patients exactly in the timing that you consider, which is what?
I will follow every 3 months.
3 months is good.
Because if you have a 30% of risk, it's
makes sense.
Yeah.
Every 3 months since you diagnose this shallow irregular RP elevation, right?
Mm-hmm.
Next item, cuticular drusen. I think you like them.
A lot, especially because Dr. Iannuzzi loves this kind of drusen. Normally we see this kind of drusen in young people, and there's still discussion if this is in the pool of AMD or it's another diagnosis, but I think due to the characteristics of this drusen over time and in the aging times, I think they should be given as AMD, as part of AMD. Normally we see as really round structures, and it's quite characteristic to see this barcode appearance of the choroid. This is characteristic also, and we can correlate this barcode to the appearance of the autofluorescence and the angiography, where you, if you remember, there's like stars in the sky is the classical description of these drusen in the angiography, and we see these target lesions in the autofluorescence because of the thinning of the RPE at the apex of the lesion, and that's why we see this hypertransmission, like linear hypertransmission, due to this drusen. This is a little bit maybe mixed, because some of the drusen are cuticular, some of other maybe soft drusen, and that's a classical association with aging. Patients with cuticular drusen develop also soft drusen, so that's not weird.
So you can get more than one type of drusen.
Yeah, sure.
Obviously.
And other associations of cuticular drusen that we described in this paper is acquired by teliform lesions. They are quite frequent, and also pigmentary changes. And the most aggressive progression could be neovascularization that may appear in up to 12%. And what we found is that normally it's type 1 lesions, and lesions with neovascularization don't appear when they are really young. They mostly appear when they have over 60 years old, and mainly in patients with large soft drusen.
But you know, when you discuss about patients with cuticular drusen, I have the feeling that they are not that bad. But you're showing that cuticular drusen should be taken into account, right?
They are not that bad when they are 30 or 40. But when they get older, they have AMD normally. So they may develop a lot of complications. And I've seen patients with cuticular drusen with really highly progressive geographic atrophy. And that's also a problem, because neovascularization, at least we have treatment. But yeah, I will not say they are benign.
That's the point. So we have cross also cuticular drusen. Let's move to reticular drusen. What's the main hallmark feature of cuticular drusen? Sorry.
That they are not drusen.
Reticular drusen.
Pseudo-drusen.
Pseudo-drusen, reticular drusen, SDD. So what's the name that you like the most? What's the consensus for that?
Normally, now it's called subretinal drusenoid deposits. And if you call reticular, it's reticular pseudo-drusen, because normally drusen are below the RPE. And for SDDs, subretinal drusenoid deposits, they are located above the RPE, invading all the outer retinal layers.
I have a question. I can clearly see what you are saying here. What about here?
Well, it depends on the status of the lesion, because they have different patterns. We have sometimes a dot pattern and sometimes a ribbon pattern. And there are different stages over time.
So you consider within the blue circle that those are SDD also?
Yeah, but not as big as the others, because they suffer a reabsorption over time. But leading to atrophy of the outer retinal layers. So it's not really fun at all.
At the end, we're looking for particular deposits, drusen-like deposits, located on top of the RPE. So in terms of the structural OCT, it's quite easy to recognize them and differentiate them from the other type of drusen.
Yeah, but I will not say that it's that easy as the example you're showing here. Sometimes you find more like the margin on the right side, these kind of images, and that's kind of tricky to recognize if you are not really used to see supraretinal drusenoid deposits. For that, I will advise to use either autofluorescence or near infrared reflectance, because you see really hyporeflective spots really clearly.
That's good. So these are the staging that you were talking about, right?
Mm-hmm.
You can barely identify that in the OCT. They grow in a very limited region, and then they erode the outer retina and grow through the outer nuclear layer. Okay. Do they have a significant impact in the vision of patients, although they don't develop atrophy or CMV at some point?
Yeah, because they are invading this photoreceptor layer. So if you do microperimetry or contrast sensitivity, is going to be decreased. And that's something that we should advise patients, for example, undergoing cataract surgery. That's really important. I mean, although the retina looks quite healthy, if we don't look really carefully, those patients, maybe they don't see 20/20. So it's good if we advise from the beginning.
That's a good point.
That's the image that I was referring in the near infrared. If you see all these hyporeflective dots, those correspond to supraretinal drusenoid deposits.
And what's the lesion in the subfoveal area?
So again, as we saw with the cuticular drusen, those type of deposits are also associated with acquired vitelliform lesions.
Okay. We also have reticular drusen. Let's move on to soft drusen. Any particular situation or consideration for this?
Volume, it's been related like that higher volumes are associated with more atrophy.
Mm-hmm.
Also, if you have drusenoid deposit, drusenoid detachment is also
okay. When you mean
worse.
When you say volume, what do you mean?
Well, there are devices that provide a volume on the drusen.
The volume occupied by the soft drusen, or the volume of the drusen by itself?
The volume of the drusen higher than 0.03.
The extension of the drusen itself.
The volume,
okay.
Not the area, the volume of the drusen.
But people only talk about the area.
Well, if they are located in the center and you see a lot, it's worse compared to if you see a sparse soft drusen, of course.
Mm-hmm. Okay. And what about this?
It's a noisy OCT.
It's a noisy OCT where you can easily recognize, not me, but you are, that are a really smart physician. Is there any finding that makes you suspect of something?
Supraretinal drusenoid deposits?
Is that columnar hyperreflectivity meaning something at all?
Maybe, but I don't see exudation. There's a hyperreflective foci next to this column.
I will bring you this patient 1 month later to you.
I will follow up carefully to see if it's an early type 3. But
it was.
Okay.
And you were talking about confluent soft drusen drusenoid PEDs. I can see a little bit of subretinal fluid there. Is there an indication for treatment in such cases?
Normally not. It's more like a positional status of the retina that cannot fold and follow this elevation.
Mm-hmm.
But I will carefully also follow this patient to see if there are changes maybe in 1 week or 2.
Okay.
And also OCTA nowadays is really useful.
I don't like OCTA.
Okay, I like it.
Okay. One more thing. I think you really like this also. I have no idea to explain what hyporeflective drusen are. Please go ahead.
Well, what we saw is just the skeleton of a soft drusen that was there, but now we have a calcification or mineralization of the drusen. So there's no RPE, and that's the problem with this hyporeflective drusen.
Is this what Giuseppe Craig has called ghost drusen?
Yeah, it's the
Okay.
same. So there are different names, and what we see is just an atrophy of the RPE due to this calcification, and the prognosis is really bad because we have multifocal areas of atrophy that become confluent, as we see in the image above. So it's not a sign that we want to see in our patients.
So for example, in such case, I can see similar patterns to that you have just described. Do you agree?
Yeah, so there are different drusen that have this hypertransmission in the choroid. So we have to suspect already the areas of atrophy in the RP, and also these hyperreflective nodules within the drusen. They are also normally hydroxyapatite crystals.
Okay, let me show you the fellow eye.
Yeah, so we have patchy areas of atrophy, multifocal, and also again this hyporeflective drusen.
So you predict that where those hyperreflective drusen are located, the atrophy will grow through that area. Is that right?
When you have hyporeflective drusen, normally you have already some kind of atrophy.
Mm-hmm. So I can see here an almost normal drusen.
Mm-hmm.
Okay. Your hyperreflective calcified drusen, and you have atrophy, RP and outer retinal atrophy established there. All these signs are intermediate AMD as far as the atrophy is not located at the fovea. Do you think that's fair for this patient?
Well, not really.
Not really. Again, we see that skeleton that you were elegantly explaining to all of us. All these hyperreflective drusen, many times, are underdiagnosed. This is the same patient. So what we see in the OCT scan at the bottom, subfovally, is the same thing?
No, it's
No.
a plateau.
Plateau?
So we?
Yes. Oui, madame, please.
Sorry. So when we see hyporeflectivities in the retina, and we suspect that previously we had a drusenoid attachment, we have to also have in mind this plateau sign, also described by Giuseppe Kirkes as a hyperreflective wedge, which is kind of confusing because it's not in a wedge shape. It's more like a plateau. That's why the group by Dr. Freund renamed into plateau. And those correspond to basal laminar deposits after the reabsorption of a drusenoid PD.
So these are hyperreflective drusen, and
this is a plateau.
This is a plateau, okay. I understand. So let's move on. Hyperreflective foci, what to do with them? Are they relevant? Are they important?
Yeah, important risk for atrophy progression.
Mm-hmm.
So, I mean, you cannot treat anything, but you can see if they derived into atrophy.
I am a bit confused with hyperreflective foci because even in diabetic macular edema or retinal vascular diseases, we talk about hyperreflective dots.
Yeah.
So foci, dots, all of the same?
Well, I don't think on OCT you can, I mean, of course, you know, if it's, there are hard exudates in diabetes or there's pigment in AMD, but there's no hallmark in OCT that gives you information to separate the content and differentiate the content. In publications on clinical pathologic correlations with Dr. Curcio, we saw that there are some hyperreflective foci that are related to pigment-derived cells, and some other, in some other cases, we saw that they are cells filled with lipid or maybe activated microglia. So it's really difficult to see and say this is something. If you see hyperreflective foci and in the fundus you can correlate with hyperpigmentation, then you know it's pigment derived. And if it's correlated with some yellowish appearance in the fundus and it's a vascular component, or maybe a type 3, it's more like lipid. But yeah, for the microglia, I don't think we have a real marker.
So it's impossible to say really, just by the structural OCT appearance, what are they exactly? Yeah. Okay. Next item, we see this tessellation in a patient which is not myope. This is typical for age-related choroidal atrophy. We should not forget about this either. Both eyes, the atrophy of the choroid leads to visual impairment just because of the thinning, and also there is a typical phenotype of age-related choroidal atrophy, subretinal drusenoid deposits, and the development of type 3 lesions and atrophy. Age-related choroidal atrophy is silent with the autofluorescence. We are not talking about RPE, we're talking about the choroid. And as Dr. Spade published, it is considered age-related choroidal atrophy to subfoveal choroidal thickness inferior to 125 microns. But also, please remember to take care of the optic nerve. There is a significant association with normotension glaucoma, up to 1/3 of those cases. So please, when you see age-related choroidal atrophy, perform a peripapillary radial circular scan to assess the thickness of the retinal nerve fiber layer also. Rosa has mentioned several times these. These are acquired by telephone lesions. And this is the typical appearance in the structural OCT images, right?
Mm-hmm.
So are they benign?
No, because the risk of reabsorption is high. So it's going to lead to either atrophy normally and sometimes neovascularization.
So it's something that we should follow.
Sure.
And how would you define that appearance? There are several parts.
What I would suggest is always look for the ELM, because the external limiting membrane is preserved normally, and that differentiates acquired vitelliform lesions from other hyperreflective lesions in the subretinal space, like type 2 lesions. And also you will see that that's the ellipsoid zone, and you will see that RP is below the lesion and it's flat, so it's not elevated. Those are melanin and lipofuscin components of the acquired vitelliform lesion, and the RP is below and flat, and you don't see Bruch's membrane.
That's a good point. So they look like this yellowish appearance,
Mm-hmm.
egg-yolk-like appearance, and obviously they hyperautofluoresce. Is there any key to recognize this kind of images without performing a structural OCT?
Well, the blue filter, yeah, it's useful to differentiate these kind of images compared to subretinal fibrosis. In the subretinal fibrosis, you will see hyper-reflective or bright structures. With the blue filter, the acquired vitelliform lesion is filtered, so you don't see, you see like a little bit of disappearance or vanishing of the lesion.
Got it. Drusenoid PEDs, you mentioned that.
Yeah, be careful with the thinning of the RP, thickening, or hyperreflective foci above the lesion, because this precludes the progression into atrophy. And normally we have a slow growing and a fast reabsorption that it's going to lead to an area of atrophy, normally.
So we should monitor these cases.
Of course, yeah.
We don't inject them,
No.
but we assess the prognosis on the basis of structural OCT images.
Mm-hmm.
Got it? Because they collapse. What's the rate of collapse?
About 25-30% in 5 years. But it also, I will say, it depends on where's the status. I mean, if it's growing, you know, you have some time till it collapses. When it's starting the collapse, you know, it's going to be quite fast.
And what about outer retinal atrophy? What's that?
Well, we already mentioned when we were talking about subretinal drusenoid deposits, and it's something that if we don't look carefully at the OCT, we can really miss, but it's really important for the quality of vision in the patient. It's just like atrophy of the outer retinal layers with preservation of the RP.
Because I see the RP is okay, we have no hypertransmission, but the outer retina is gone. So the definition by Dr. Spade was what you mentioned. You cannot identify outer retinal structures, even though there is no neovascularization or atrophy. And he even proposed a third type of advanced AMD form. Do you agree? You dare to disagree with Dr. Spade? Okay.
No, I'm not going to disagree with Dr. Spade. I think the CAM group, and including Dr. Spade, they did a great job in the classification of atrophy, and I think we will talk about that maybe later. But I'm not sure if it's another type because it's all overlap. So I will not split in more types of advanced form, just to like understand what we are seeing.
Fair enough. So we have completed our intermediate, if we can say so, AMD checklist. Let's move quickly before Ricardo closes this connection, because we were saying that these things are particularly useful. Why?
Well, the thing is that I really, when I first saw this paper, I thought it was really good for the clinic. The group in Los Angeles by Dr. Sada proposed to take these three features: hyperreflective drusen, hyperreflective foci, subretinal drusenoid deposits, and the volume of the drusen, and give points if we saw this in one eye or two. And that will lead to the risk of progression into advanced forms of AMD in just 1 year. So I think the difference between having 0 points is amazing compared to having all these features in both eyes. So you are moving from 0% of progression into atrophy or neovascularization in 1 year to 73% of risk.
So depending on the findings that you see in the structural OCT, you can schedule different approach for the follow-up of those patients?
Yeah, if I don't see any of those signs, maybe it's 12 months, yeah. And then I will move, yeah. I agree with that.
And you only have to recognize hyperreflective drusen, intraretinal hyperreflective foci, and SDDs, or reticulocyte drusen, right?
And and a lot of soft drusen in the center.
Okay.
Yeah.
So this is quite practical. I like that. Very quickly, Ricardo, Eduardo, please, very quickly. Don't panic.
You have plenty of time, my friend.
Thank you. Just in case. This is more easy in terms of, I think Bailey Freund did all the work for us. Remember that when he published this back in 2010, he already said that FA-based classification was clearly not enough. First, because we cannot perform FA in every particular case of AMD, given the burden of such many patients coming to us, And because we were doing OCT scans in every single eye of every patient coming to our clinic. So it made a lot of sense to do this approach with structural OCT, multimodal imaging approach, but mainly structural OCT to classify different neovascular lesions according to the structural OCT appearance. Type 1 lesions, type 2 lesions. Type 1 lesions located under the RP, type 2 lesions on top of the RP within the subretinal space. And this was correlated with the histopathologic findings published by Dolz and Hans Gross earlier when they were examining the surgically excised neovascular lesions. And with histology, what we can see is that really the OCT scans represent perfectly those 1 and 2 lesion types of neovascularization. We need to add what Dr. Denoising described as retinal angiomatous proliferation, and Dr. Freund included this as the type 3 lesion in patients with neovascular AMD. So in summary, we have type 1 lesions under the RP, type 2 lesions on top of the RP, less than 10% of cases in AMD, and type 3 lesions, intraretinal neovascularization. We should add to this aneurysmal type 1 lesions that may eventually grow within type 1 neovascular lesions, formerly called polypoidal choroidal vasculopathy, but in this brilliant paper, the authors explain why polyp and choroidal is something that doesn't seem very suitable for this disease. So it's prefer the term aneurysmal type 1 neovascularization. Also, Rosa, together with Bailey, published this particular conversion from a clear type 2 lesion to type 1 lesions, and this obviously changes completely the prognosis of that case. This regression of type 2 lesions into type 1 should be documented because the need for further injections, the visual prognosis, the risk for atrophy clearly changes. And remember also that type 3 lesions are associated with multifocal RPE atrophy. And in terms of the long prognosis, this should also be taken into account. And now we move to atrophy, which is the comfort zone of Dr. Dolz, Marco. As you know, she has performed a crazy number of studies, publications, and presentation on this. So I'm glad to let you go with atrophy.
So with atrophy, we have to classify and know what we are seeing. In this case, for example, we see that the outer retinal layers are gone, but the RP is still preserved in some areas. So we will not call this geographic atrophy as we normally do in the clinic. We have to see with OCT what layers are missing and specify that.
What's the vision of this patient, more or less?
Maybe 0.7, like 20/30, or I don't know.
I don't know.
But it's, so what I was saying is that if you see the image, there are areas where we clearly see the signs described as geographic atrophy. We see the choroidal vessels in the color fundus. We see hypoautofluorescence in the autofluorescence. And those areas corresponds to atrophy of the RP, that it's of course associated with atrophy of the outer retina. And this, it's called now RORA, so RPE and outer retinal atrophy. But if we look around these areas of hypoautofluorescence, we will see that there are areas of hyperautofluorescence. And normally we see that kind of feature in the autofluorescence when we have missing tissue in the retina. So only the outer retina is missing, So that's an unmasking effect. So we see more the hyper-autofluorescence of the RPE, and that's why we see hyper-autofluorescence.
It's kind of a window defect on fluorescent
Yeah,
angiography.
it will see like a window defect, but for autofluorescence, and it has been described as unmasking effect. And this is called outer retinal atrophy, aura. So we only have atrophy of the outer retina, but the RP is preserved. So aura for outer retina and RORA, adding the R of the RP for the combination of the two.
You know, I don't like the names at all.
I like the names because they are really easy, and I always am against you, so yeah.
That's okay.
No
But
problem.
I don't like saying you have aura to a patient. I don't know.
Maybe in Spanish it's not that good, but yeah.
But flora is not better. So please go ahead.
Yeah, so this is the consensus of the classification atrophy meeting, where many experts around the world met, and they decided to put more clear classification on the geographic atrophy patterns. In fact, we should avoid to use geographic atrophy in general, unless we are sure that there is no neovascularization. And if we describe the OCT features, we should say complete outer retinal, so complete RORA if it's more than 250 microns, or incomplete if it's less. And also aura, C aura or I aura when it's only atrophy of the outer retina.
Actually, it's getting better with the C and the I, the name. I don't know why you like it.
I think they are working still on purifying the classification, but I think this was a big step on clarifying on how to call all these findings. Also, there's the term macular atrophy that we should use when there's combination of neovascularization with atrophic signs, because there's no geographic atrophy possible. So it's macular atrophy.
So we know that Ricardo kindly was discussing this the other day with all of you. But Rosa, how do we measure, sorry, I'm going to just say this properly, C-RORA on OCT?
Well, the thing, normally we see the hypertransmission on OCT, but it's true that there are other signs that we see, like the subsidence of the OPL or the loss of the external limiting membrane. And we study that. In some eyes, we see that the RP seems that follows in the area of atrophy. So we see hypertransmission, but we are still seeing the line of the RPE. Some of these are not really RPE cells, just basal laminar deposits, but it's quite confusing in the OCT to establish a clear margin. Sometimes it's also tricky because we have like linear hypertransmission, but not really a clear area of atrophy. And again, the RP or basal lamina there. So the RP, it doesn't end in a really clear margin, but a rugged margin. And sometimes we have to find other margins. And what we described, because Dr. Cuccio is used to use this kind of margin, is the ELM descent, which is the loss of the external limiting membrane in the areas of atrophy. So we delimit the areas of atrophy of the photoreceptors by this descent of the external limiting membrane.
So I have a question. There are a lot of new therapies for geographic atrophy, RORA, coming. Is this of any value? Another way of saying that, should they consider ELM descent as a primary anatomical biomarker for the efficacy of such treatments?
Well, what you see with the ELM margin is the margin between photoreceptor loss and preservation of photoreceptors. So I think it's a valid margin that we have to use in addition to other things. It's true that it's more difficult to be as analyzed maybe compared to hypertransmission, but I think it's a valid point that we can clearly correlate with histology. So, and in fact, this ELM descent was long time ago described by the SARCs in Australia. So we know that the pigment epithelium ends with proliferation, so it's not really a clear margin. We have photoreceptor loss and progressive degeneration, and the ALM ends in a curved line. So they already described this descent. So our question was, can we see this descent in the OCT? So this is again the same. So all the ELM is differentiating the area of atrophy of the photoreceptors compared to the area of preservation. And the ELM, the good thing is that we can see this descent of the ELM on OCT. And in fact, if we track, for example, this patient with Stargardt's disease over time, we will see that as she was progressing in the atrophy, we see this descent scrolling and at the end forming this outer retina tubulation. So what we are seeing in the margin, this hyperreflective margin, is the ELM descent growing. So the area of the atrophy growing over time. And we also correlated with clinical pathologic eye, where we saw that this ELM descent was clearly visible and comparable to the histologic images. So I think hypertransmission is really useful, but it's measuring different things. Sometimes we don't have a clear margin on the atrophy of the RPE, and we have areas of the hyperautofluorescence that are not clearly defined as atrophy or not. So we can add this feature to really see if we can add information.
Rosa, just to let you know, we have discussed Tuesday exactly this article, this paper that you have just showed us. Brilliant, the correlation.
And did you like it, really?
Yeah, really.
Okay.
I love that nomenclature too.
Yeah, I think it's something that, as I was saying, it's maybe more difficult to analyze, for example, in reading centers, but and also it depends on the quality of the scans. We saw in our paper that you have to have really good quality scans in order to see the descent in all the patients. But I think it's valid because the margin, the RPE and the ELM descent could be really in different points in the retina, as we are seeing here, in a big percentage of areas in the margin of the atrophy. So that's important to keep in mind. So depending on what we are seeing, we are measuring one thing or the other. And also what I was mentioning, the quality we need, we were using, for example, here Spectralis, but with other devices will be the same. We need good quality of scans to really achieve the visualization of this margin.
So to summarize, I think we all agree that we need to really purify the strain of AMD more than we are used to. We have reviewed some risk factors related to Drusen and deposits in intermediate AMD. We have quickly underlined the importance and the relevance of phenotyping macular neovascularization, and Rosa just elegantly showed the new insights into diagnosis and follow-up of cases of outer retina and RPE atrophy, aura and RORA. So we have a lot of new information, a lot of OCT, structural OCT-based information coming to our mind in every single patient with AMD that we see. And that's why we are extremely thankful to Ricardo and all the group, Eduardo, all our dear friends, for the kind invitation. We enjoy very much all these talks. We apologize for the delay, but you have seen that Rosa was very talkative today. And thank you very, very much for your invitation and attention. Thank you.
Roberto and Rosa, the only word that I can say, it's awesome, because a lot of our residents and colleagues are just sending me messages telling that they have never seen a class, a lecture, like a debate. It's just like we do on the OCT when we are on the clinic. So it's like me, Eduardo, Almir, and telling someone, just questioning and getting answers and comparing the OCT, so, but in a different way, because you two are experts. So when you make like a debate, it's it's a unique form to give a class. Yeah, I loved it very much.
You cannot even imagine how my life and my entire life is a debate.
But that's fun.
I imagine that. Yeah, but it was great. I don't know if someone, Eduardo, want to comment something, Almir, and someone from the audience.
I would like very, very nice information, very good lecture, and both of you. There is a term, Rosa, I think when Heidelberg gave a meeting, was a meeting in your place 3 years ago. Remember that? You gave us, I saw that lecture where you mentioned a term that I was not able to find. What is pseudo-swelling? Remember?
Yeah, so the pseudo-swelling is a hyporeflective wedge that we see at the margin of the atrophy. And this was described by Dr. Moniz as hyporeflective wedge. Yeah, so yeah, pseudo-swelling, we used to use this term because at the beginning, Dr. Moniz hypothesized that maybe it's a swelling of the Henle fibers, but it's not really an edema. So that's why, yeah. But in fact, the true name, the term, as it was described, was hyporeflective wedge.
Okay.
And that's a little bit confusing with the hyporeflective wedge that Dr. Kerkes described. And that's why the group in New York proposed the plateau sign, because there are two wedges. One with a wedge shape described by Moniz at the margin. This is hyporeflectivity. And then the plateau that we saw at the beginning. Yeah.
Another question, which is important. Another one. And what about what are you prescribing or recommending to those people with the soft juice? And the question is, are you prescribing or not some kind of vitamins, or asking to avoid anything, or what do you do in practice?
With intermediate AMD, I try to prescribe, because at least it's the only thing I can do. I advise to quit smoking, have a healthy diet, and wear sunglasses. And I explain that the only thing they can do in addition is taking some vitamins. I don't put the expectation high. I just explain that there's some information that we see some decrease in the progression, but yeah.
I respectfully disagree completely. I never recommend vitamin supplementation to any patient. Actually, I ask that lady or gentleman to invite his wife or husband out for dinner once every month.
For a wine.
Because they are extremely expensive. And as you perfectly know, the only evidence that we have to prescribe that is to decrease by 1/4 the risk of developing neovascularization in the fellow eye. I prefer to monitor with OCT those cases instead of having them investing a lot of money for something
But it's
tricky.
25% reduction. I think it's quite.
But we need to
good.
perform more injections.
After
Rosa.
8
Okay.
Roberto,
And I have,
Roberto and Rosa, let me introduce another, like you, since during your lecture, you have talked about OCTA. That's a great guy from OCTA had want to say hi to you and say something. Andrea Romano is in the audience. Please, Andrea.
Hey,
Hi.
Rosa. Hi, Roberto. How
Hello,
are you?
Master. How are you? Good to see you.
Good. Fantastic. I really, you guys aced it and really summarized, phenotype and intermediate and advanced AMD. Really fantastic. Very elegant. The way you both communicate with each other. It's very funny as well.
Okay, that only happens in front of a PC, laptop. Thank you.
Ricardo, I have a question.
Nelson, the other boss, Roberto and Rosa, we have two brothers.
No.
Nelson and Almir Sabras. This is the older one. Not so old as Eduardo, but an older one too.
Rosa y Roberto, muchas gracias. É increíble la charla. Okay?
Muito obrigado.
It made me feel like I did my training in Woodfields. And for instance, you guys talking remind me Professor Bird, the way you explain, the way you talk, amazing. Very nice. Okay, thank you very much.
Oh, that's a lot to say. Thank you.
Thank you.
How do you guys, in the beginning, Rosa was saying that she likes OCTA and you don't like it. So what's your thoughts about it? When you have a patient with dry AMD and you're not sure if there's a membrane or not, do you go for OCTA? What do you think about it? Andrea Romano can share with us also his opinion.
Yeah, I mean.
Now I am under a lot of pressure because Professor Romano is here, so I cannot. But let's have Rosa answering to that before.
No, I think it's a really.
I don't want to make any problems tonight for you guys.
No, but he was the one saying he doesn't like OCTA, so that's his problem. No, I think OCTA, of course, it's starting still because it needs to improve speed and all, but I think it's really useful in cases, as you were saying, that are in between neovascularization and not, because sometimes with just the structural OCT, you're not really sure. You see some cystic changes, and if you perform OCTA, is really valid in that cases in between. Because with fluorescein angiography and atrophy, you see hyperfluorescence, and it's not really easy.
And a very practical thing, I think, is that in AMD, I think it's extremely important to go through the B scans with the flow overlay. At times we look for the avascular zone and try to make ourselves the slab that we like the most. And in patients with intermediate AMD with a lot of subdrusen, a lot of atrophy, many changes that can induce artifacts by itself, trying to get a perfect slab is challenging. But looking at the B scan with the flow overlay all through the OCTA scan that you have performed, I think it provides a lot of information.
You didn't mention why you don't like OCTA. You're saying how to use it.
And that's the thing that I like the most about OCTA in patients with intermediate AMD, to look at the B scan with the flow overlay, these nascent impending tight field lesions that we were showing, try to rule out the presence of neovascularization in cases with drusenoid PEDs, acquired by telephone lesions with partial reabsorption of the bitelephone material. There are many, many cases where OCTA is extremely useful in our patients. I can tell.
Yeah, I think, my training at Woodfields was in medical retina and retina, in surgical retina, but I basically do surgical retina, but I do medical retina as well. Mm-hmm. We have the OCTA, but what I think it's hard, and I think Andrea will follow me, try to answer what I will say, but segmentation, I think, is a hard, is the thing that I find it very hard sometimes to do a good segmentation to see if it's a true neovascular thing or not. So
not now. No, working for you.
Well, so that's what I think, as a surgical guy. But Andrea can go ahead, Andrea, please.
Yeah, I think both Roberto and Rosa are right. I think one of the difficult times in using CTA is that this lab does not understand the AMD disease.
That's a wonderful point. Yeah.
Yeah. So it's the greatest difficulty that we have is actually to place this lab in the right location. And today, this lab is actually defaulted by the company. And so that's the biggest thing. So in order to understand OCTA very clearly, you have to go through all the scans and see where this lab missed the disease, and sometimes to propagate manually correct, and try to propagate through all the cube. The second thing that Rosa mentioned very nicely is that the biggest issue that we have now is the speed right now, and so we're not able to see. We have a lot of artifacts still. However, there's something new that's coming to all the companies, and I'm participating in two of them. It's a new artificial intelligence algorithm called Denoising. Denoising, it's really fantastic because right now, when we need to see a three-dimensional or a cube or whatever of CTA very nicely, we need to average maybe twice or 3 or 4 times DLCTA images. However, and it also happens with a B scan. Sometimes we even have to, for instance, some of the companies average 100 times, 120 times, or 50 times. But with denoise, the nicest thing is that you don't need to average anymore. So one thing that it's happening with this neo algorithms is that we're able to see very nicely B scans with only 1 scan. So that probably will compensate the speed for some time. And so that's really fantastic. And the speed now, companies are investing in speed, but however, it's very, very expensive to have a swept source OCT with a 400K and so on. So I think that's why I tried.
Yeah.
Sorry?
You miss signal if you are too fast.
Exactly.
Yeah,
so that's what I was going to say. So the group in Munich have this fantastic machine that goes, there's voxel OCT that goes to 1.1 to 1.9 million, 1,900,000 A scans per second. The image that we see, it's really amazing, but exactly what Rosa said. So what were we seeing are real, or are they averaging a lot to not miss a scan, to not miss a pathology? So I think the future, for the next 5 years, is to is denoise with some tricks in there, some optical tricks. And the speed, we're gonna leave the speed for the future. I don't know what you guys think, Roberto and Rosa.
Yeah, well, yeah, I think there are many. That's why I say that I think we are still facing the beginning of this technique, because we have to change a lot of things. We have to change our mind also. We have to work more like a radiologist service. Our computers are not useful to have such a big amount of data because they are crashing all the time. So yeah, we have to change a lot of things, and yeah, money, it's a problem. But yeah. Speed, it's one thing. AI, it's of course there. And I think you mentioned already, but the 3D capabilities of OCTA, I think that's really powerful. Yeah,
we're using it, but it really misses a lot, as Roberto said, because if the patient doesn't fixate just a bit, and it's like the OCTA in the past. And when we start using 2011, 2012, it's like one vessel here, the other one like 5 kilometers away. So it's a matter of fixation. But I think maybe AI with denoising, it's the way to go, even for 3D LCTA.
Yep.
Absolutely agree. Yeah.
Yeah. You're muted, Japi.
Sorry, Edu.
Oh, I was gonna. It's time to finish already, or not?
No, if you want, you're the boss. You tell
I'm
me.
not the boss. I'm not the boss. We have to take the chance to have the couple. The couple, by the way, the couple. How do you say Rora? And you two are Roro, because Rosa and Roberto. The Roro couple. In terms of practically speaking, the term, if you see a patient with those new things that you were describing with Curcio, practically speaking, what can those signs that you just mentioned to us can help us from now on? Because a lot of people here, they're more starting and seeing things now.
The descent of the ELM, the Rosa and Nora. So I think you can answer, but I think they are worth signs or worth biomarkers to the treatments that are ongoing, are being studying about dry AMD and so on. But say what do you think, Rosa? And
yeah. So the thing is that, for example, for Rora and Ora, the terms, I think we should, especially if you are a resident, you should try to start using the correct term in an international consensus. And I think for AMD, we are lucky because a lot of experts have been working a lot lately with new terms. And I think they are quite correct and correlated to the techniques we have right now. For the ELM descent, maybe in the daily clinic, we don't use that daily, but I think it's useful when you analyze a patient with atrophy and you don't have autofluorescence. Many places, they don't have autofluorescence, and that's not to be panicking. You can still see atrophy really nicely. You can see the hypertransmission and you can see the ELM descent and see if the patient is progressing or not, just with the OCT. So of course, autofluorescence adds a lot of information and provides you other signs, but it's not the only way to analyze and diagnose atrophy.
Because
you can use the Unfaso CT as well, not only the B scan. And maybe play with a slab.
But where? So yeah, so my question related how we measure OCT is related to that. So on the AMFAS OCT, you can see the area of hypertransmission, but you can also see, as I showed, the area of ELM loss. So ELM area of degradation. Yeah.
There are a lot of questions coming up in the chat about all this that Eduardo raised.
I didn't know.
And I understand the point that this is some kind of, okay, this is beautiful. You have a lot of beautiful structural information. So what?
Yeah.
Do we really need to spend 5 minutes looking at a structural OCT? To what? I think knowledge is essential in our field. I think we're moving towards a really specialized and sophisticated work in terms of medical retina imaging analysis and neovascular and atrophic AMD treatment. We do need to recognize, understand, and of course, make our own observations on all these things that Rosa was saying. It's not something useless. I'm pretty sure that they will be adapting structural OCT measurements with these new Brimonidine, Zimura, and Pelis, all these new treatments that are coming up for the management of atrophy. So I think I encourage everyone to really spend 1 minute looking at structural OCTs and recognizing all these features, because that's the best way to communicate with patients. You can show them the image and with the eye tracking follow-up, the progression. This is not only educational, this is not only a webinar thing, it's a very daily practice. It requires a lot of information and a lot of training to quickly recognize everything. But you can make yourself your checklist in the medical chart of patients, and you can only you only have to cross whatever it's present, and then you adapt your follow-up to the evidence-based medicine that we have today. So I understand all the points that are discussing in the chat, but again, knowledge is extremely relevant for patients' care.
Always, I agree.
Very good information and points. Fantastic, Japi.
So I think like Eduardo said that, sorry, Amir, you can tell.
Roberto, thank you so much for the amazing lecture. You guys are a couple of Retina as well, the Shields Families Oncology. So, so thank you so much.
Thank you so much. Now you have your time. Maybe it's 9 p.m. or so what in Spain, so 9:30 already. So you can rest a little bit. And thank you so much for the awesome class. So we hope to have you here with us in the near future with some other team that you want to talk to us. Okay.
A pleasure.
A huge privilege. It's always great to see you. And take care, all of you, please. See you very soon.
Thank you so much. Thank you, Eduardo, Andrea, all the audience to be with us.
Thank you, Eduardo.
Oh, thank you so. You deserve it.
Thank you, Ricardo. Everyone, please.